I've had an incredible conversation with Dr. Jesper Eugene Olsen, a pioneering biochemist with over 28 years of experience in chronic inflammation research. Jesper leads innovations at his Copenhagen clinic, specializing in biomarkers like suPAR to assess biological age and disease risk. Jesper has transformed our understanding of how chronic inflammation affects the immune system and overall health and longevity. His development of the suPAR test provides valuable insights into aging, cardiovascular health, metabolic disorder, and mental health. I first met Jesper at Copenhagen Health Week, where his talk on inflammation was truly inspirational. I also had the chance to visit his clinic for an inflammation and aging assessment. It was quite an amazing experience that I highly recommend. Today, we'll dive into the science of chronic inflammation, explore how suPAR can predict aging and disease, and discuss lifestyle factors like diet, stress, and exercise, and how they influence inflammation. If you're curious about how your stress, diet, and lifestyle choices impact your long-term health, you do not want to miss out on this episode. We will be talking about how tracking these biomarkers can help with prevention and long-term wellness. And at the end of the episode, I will reveal the results of my suPAR test that I did just after this episode recording. So be sure to stay until the end to hear what my suPAR result was. And now, without further ado, I want to introduce you to the man behind the suPAR test, who has also been coined the suPAR man, and I'm sure you'll find out why very soon. Jesper, good morning. I'm delighted to invite you to the Charlène Gisèle Show. How are you today?
I'm great. I mean, it's been a fantastic weekend. I met you
Mm-hmm.
and a lot of other fantastic people at Copenhagen Health Week. And I think it was a good time. It's beautiful weather in Copenhagen right now, even though we're at the end of September. And a lot of things are, the city is, go visit Copenhagen if you haven't been here. And I know you had a few good days here.
Oh, yes, wonderful. I met the Little Mermaid.
You did. That's so disappointing, isn't it?
Well, she's smaller than I thought.
Yeah, we cut off her head once in a while, to make her interesting. Somebody steals her head and paints her. And
I heard the arms as well. The poor thing.
Yes.
She's gone through it all.
Hans Christian Andersen wouldn't be too happy.
Oh.
No.
Well, I'm still glad that I've got my little souvenir photos there. Well, Jesper, the reason I invited you today, and I'm so delighted that you've said yes, and we made it happen rather quickly. We met the day before yesterday when I attended your really powerful workshop on the topic of inflammation. And as I heard you on stage, I thought, okay, this conversation needs to be broadcasted on my show because I know that it could help so many of our listeners. So Jesper, I would like to invite you to perhaps start with a bit of an introduction. Tell us more about you and what has compelled you to work in the field of inflammation.
I started a company many years ago. I've done a lot of patents on suPAR, and I started a company called ViroGates. It's actually named after Bill Gates, but I'm a virologist also by training. And it's linked. It's on the Danish stock market. So we have stocks out there every day. I have a lot of commercial interest, but I worked in the public system for these 28 years. So I just want to say that it's not really. It is important, but so I needed to say that. Yeah.
Of course.
I mean, money doesn't matter that much. What really matters to me is to do something that creates some kind of value. And sometimes, the best things in life, that's the ones. I was giving a talk at an emergency medicine conference once. And this woman came up to me afterwards and she said, "Yes, well, I want to talk to you. I want to say thank you." I said, "Oh, sure, I don't know who this woman is." She was a 48-year-old nurse. And she said her doctor, some doctors in Denmark do suPAR as part of the health examination. she was tired. She was a little bit, and but the blood work was normal, but the suPAR test was 8, which is really high.
Really high.
Yeah. So the doctor, said, I think I'll send you for a MR scan. And it turned out she had a tumor in her kidney, and she underwent immediately surgery and got it removed. And she came and said, Jesper, you saved my life. And that's really what value in life is all about. And then about being honest, I want to say I, published data, peer-reviewed, and if you are ever a scientist or you are a scientist out there, that's all you have. That's your honesty and your treatment of data. So that's really important to me. But so I'm 60 years old. I'm educated as a biochemist a long time ago, and I did my PhD in genetics. And I was fortunate to start up a research group and be heading a research group for 28 years at a hospital, a university hospital. And that allowed us a lot of access to patients. And we've been very focused on what can we do to improve our patients' lives. And during that time, we've been very interested in prognosticating, meaning that we want to look into the future of patients. And that's also important in the hospital. One of our big problems is that we send patients home, but they come back. And can we prevent that? Can we identify those patients who have a high risk of being readmitted or high risk of dying, so we don't send them home, but keep them in hospital? And I've been fortunate to have a lot of more clever than me people around me, a lot of medical doctors doing their PhD in inflammation. You can say that we discovered during all this work that one of the most important things we could access and to determine the risk of mortality and determine the risk of readmission was if they had a high level of immune activation and chronic inflammation. And it's really interesting because we have discovered, you could say that we actually came from thinking that chronic inflammation always was in deceased individuals. We found out that all the way back in the 90s, we found that HIV patients who had high level of chronic inflammation, they progressed more fast to AIDS. And then we got treatment, but it was still really a strong biomarker of their risk of mortality, even with the treatment. And we thought this must be something that's important for HIV because of the virus. But then we found that people who had tuberculosis and who had this biomarker, maybe I should see what it is we measure in their blood. But so basically, to make it, if I should say everything in 1 minute, I would say that chronic inflammation is something that we have understood for. It's important for our life in general, how fast we age, our risk of development of disease, but we have had difficulty measuring it. We understand that chronic inflammation is something going on, but we don't really know how to measure it. And I think, so I've been part of the inflammation work that many researchers have done over the last 3 decades. And it was back in the 90s that we have for a long time had a test called C-reactive protein or CRP.
Yes.
It's a really good test. You go to your doctor, you feel a little bit bad, maybe you need some treatment. So what the doctor will do is often to do a CRP test. And if CRP is very high, like 100 or 200 in your blood, we know it's a bacterial infection and we give you antibiotics. And if it's elevated, but maybe not that elevated, you're probably still infected, but it's a virus, and we don't give you antibiotics because they only work on bacteria. So CRP is a really good biomarker. It's something that's produced by your liver in response to bacterial proteins. Yeah. So very good biomarker. Antibiotics is wonderful. We are using it too much, and that's becoming one of the real big challenges we face, but that's not really the topic of our discussion here today. But then in the lab, somebody developed what we call an HS-CRP assay. That means a high-sensitive CRP assay. Because back then, in the 90s, we had, you had a high CRP, you had CRP, or you didn't have CRP. But with a high-sensitive CRP assay, we could suddenly measure CRP in everybody. So we could do big population study, cohorts where you have like 1,000 people that are not sick, and you measure their CRP. And we discovered something that was termed low-grade inflammation. And that meant that you had not high CRP, but not low. You had slightly elevated CRP. Now that we could measure in everybody, we could kind of see that some people had a little bit more and others had a little bit less. And that little bit difficult term that we call low-grade inflammation. I don't call it low-grade inflammation anymore. I call it systemic chronic inflammation. But it was termed low-grade because it was low, but it was still elevated. So basically, with the CRP and people who had slightly elevated CRP, we could see that they had high risk of cardiovascular disease. They had higher risk of diabetes. They had higher risk of neurodegenerative diseases. And that was a big surprise because these diseases are so different, right? Neurodegenerative, cancers, cardiovascular disease. But this low-grade inflammation seemed to be underlying so different diseases. So that really sparked a lot of research into understanding what this low-grade inflammation or chronic inflammation is. But as I said, it was done on population studies. But Charlène, sorry, that's actually Charlène. If I measured on you CRP with a high sensitive assay, you might be slightly elevated. But if I measure you tomorrow, you may not. And that's because your liver is very sensitive to a little bit of bacterial proteins. You actually get virus and bacteria into your system every day. And you might even have a little bit of bacterial protein that leaks from your intestines and into your bloodstream, microbial translocation of proteins. But that affects your CRP, and it makes it quite unreliable on an individual level to see if you suffer from systemic chronic inflammation. Right. So we have been working a lot with identifying using, multiplex assay where we measure very many proteins to see if we can find more stable, more reliable, more predictive biomarkers and to carve out this chronic inflammation into a test that you can measure. And already back in the 90s, we succeeded in identifying a molecule called Soluble Urokinase Plasminogen Activator Receptor. It's
easy to say.
Yeah, it's a mouthful. So, but the abbreviation of that is suPAR, SUPAR. Some would call me the suPAR man because I used 25 years of my life studying this molecule. And it's not only me, it's a lot of PhD students and postdocs and people doing their bachelor, and it's not only in Denmark, it's all over the world. So now there's more than 1,000 peer-reviewed papers on this biomarker of chronic inflammation that we term suPAR. So that's really what I've been working on.
And why can this be relevant, if not groundbreaking, for someone who is trying to predict or prevent a potential risk of metabolic or cardiovascular disease?
It is, I think, really, as you say, groundbreaking in a way, because it gives us what I term the intelligent life possibility. It gives you an ability to look into your immune system before you get disease. Now, we took this from the hospital, from all the disease patients, and suPAR is a really, it's used a lot in hospitals. It was it's used in the triage of patients in the emergency department. If you come into the emergency department, not all hospitals, not in England, but in many other European countries, the NHS is are under a lot of strain, and it's not easy for them to take in new technologies, I guess. But we are doing a lot of clinical trials in England right now on suPAR, but we have done them in Europe, and we use them in hospitals in Europe. And for instance, the COVID pandemic, we all remember that, crazy days. We very quickly established a consortium called the International Consortium on Inflammation and COVID-19, where we screened all these biomarkers. It was quite apparent very early, already in March 2020, that some patients who came into our hospital, in the beginning we isolated everybody, but who should we isolate? And we had quite a few, in particular during the Delta variant wave, quite a few patients that, suddenly lost their breath, and we had to intubate them, mechanically ventilate them at the intensive care department. And we didn't know, should we send patient home? Should we admit the patients? Who should it be? And our international consortium of Americans and many Europeans screened quickly a lot of patients. Already in March, April, we had the first data of these. And suPAR turned out to be the best predictor also. Having a high state, now suPAR is expressed by immune cells, and it's an expression of immune activation. And immune activation, to be quite short, is the language between immune cells. So if your cells have a lot of suPAR on the surface and in between them, then they kind of shout to each other. And when you get a virus like COVID-19, SARS, coronavirus 2, and you have a high level of chronic inflammation, your immune system is not able to cope with the challenge, and we discovered that it was those people who had suPAR above 6 that had a high risk of ending up with respiratory care. And with that knowledge, we really did a wonderful study. We set up, because European hospitals use suPAR, we set up a hospital on 37 hospitals in Europe, and we randomized, we had discovered some drugs that might help in COVID-19 by closing down the immune system. But in France, they did a study, and it turned out by blocking the IL-1 receptor, it becomes a little bit technical, but the innate immune system is really important in our defense against viruses and so on. And if you block the IL-1 receptor, you won't get a cytokine storm and a huge activation of the immune system, which could lead to the respiratory failure and chronic failure, organ failure. So they did a trial, but they stopped it early. It was randomized because they saw more cases in the active arm. This was a drug called anakinra, IL-1 receptor antagonist. They saw more cases who got the drug ending up respiratory care than not. But we had a different hypothesis. We said only if you suffer from chronic inflammation will you gain from closing down your immune system. If you have low suPAR, if you have a good immune system, your immune system will help you combat the virus. So at those 37 hospitals, we only included patients who had suPAR above 6. Mm-hmm. That's way more than you have right now, Charlène. You have maybe around 2, something like that.
Well, we'll find out. Yeah, I'm getting tested right after this.
Yes, so. That's going to be exciting. And we'll talk a little bit what that will mean for you in your personal, what can I tell you about when you test yourself as an individual?
Of course, I've already expressed concern about the fact that I'm not at my greatest peak state, recovering from dengue fever, but we'll see if that, can that show?
It is affected by all kind of infections, yes.
Oh, so
and it will also say something about how you respond to your infection. So with COVID-19, on these 37 hospitals, we randomized patients with high suPAR to placebo or close their immune system with the IL-1 receptor antagonist. And we could stop people from progressing to more severe disease, to hinder them in being mechanically ventilated, becoming more ill. Mm. And we published that in Nature Medicine, and we did it actually with the EMA, the European Medical Agency, and that was approved as a first biomarker-guided therapy in infectious diseases at all, and also by the FDA in the US.
Right.
So that was really a breakthrough for how you can use a biomarker to treat individuals. But when you later on today, Charlène, will have a suPAR test, it is not because you're very sick. It's not because I want to save your life. It's not an acute situation. So we did a lot of work, measuring hundreds of thousands of patients in hospitals. And it didn't matter what patient it was, whether it was a patient with COPD, whether it was a patient with cardiovascular disease, whether it was a patient with an infectious disease. Every time a patient had elevated suPAR, they had a worse prognosis.
Right.
They were in hospital for a longer time. They had higher likelihood of mortality. And after we've done many studies on that, and other groups have done many studies on that, we kind of asked the question, what is it that we are measuring? Why is this such a strong predictor of mortality in all these diseased individuals? What if we take this biomarker and measure it in a healthy population? Does it also mean something in a healthy individual with regard of risk of development of disease, risk of mortality? So that was a new idea that, is it what we are measuring really something that's universal, that it's always bad to have a high suPAR, not only in diseased individuals, but also in healthy individuals? So that was our next step, which it's actually 14 years ago we started thinking about that. And when we're born in Denmark, which is, it's a really nice socialist country in many ways, but it's a well-functioning country. We pay high taxes, but we have free universities, free hospitals, and so on. It's an easy country. It's easy because it's small and a lot of political parties and a lot of discussions, but I think we do quite well. But one of the things we are really world experts on is following our people. We are born with this 10-digit CPR number, we call it, personal identification number. And that as soon as you are out your mother's womb, you kind of get a number on you. And that number tracks you in all kind of registers in Denmark. So there was actually a paper in Science one by a Danish science journalist called Lone Frank saying that Denmark is the world's largest cohort, meaning we are like one big experimental group of individuals that we can follow with ICD-10 codes. If you sneeze, if you go buy medicine, if you go to your doctor, everything is registered in ICD-10 codes. It's some big registry. So if I do a study in the general population, measuring suPAR, for instance, I can go to the registries and see, did this individual later develop diabetes? Did this individual develop cancer, cardiovascular disease, a kidney disease, or whatever? So we have really good ability to do population studies, and I think we are quite famous for that around the world. And a lot of foreign individuals, Americans and so on, really want to collaborate with us because they want to get access to our personal identification and registries. And we had those thoughts about what about the population back in 2008, 2009, and we started looking into collections of blood that have been done in Denmark, where we had questions like, we want to follow individuals, we invite people to be part of an investigation. Do you want to take part in, you get it in your a letter at that time, you want to be part of investigation where we follow you for the rest of your life. And we need blood for you. And we can do DNA and we can do whatever. We can do whatever we want with your blood. And people say, yeah, I'm willing to do that if that can help science. Some people, it's voluntary. Right? And from those data, we got the first data, what we call the Glostrup or Monica 10 studies, where we had 2,600 individuals who were included as 41, 51, 61, and 71 years of age, and we followed them for 10 years. That means we could make a model for what happened from an individual who's 41 until they're 81 years in a 10-year study. And we measured suPAR in that cohort. And I'll never forget the day that I kind of, I had all the data in my computer, and I wanted to do a regression analysis, Cox regression, to see was suPAR associated with mortality, was it associated with cardiovascular disease. And the first one I did was mortality, and when I pressed the button and it just gave me some insane p-values, I said, what the beep, right? It was crazy. It was so strongly associated in general population with prediction of mortality. And then we did cardiovascular disease, yes, diabetes, yes, cancers, yes. I said, whoa, these are so different diseases and we predict them all. So we're a little bit back to the CRP story in a way that we knew from population studies that low-grade inflammation or systemic chronic inflammation or just chronic inflammation is an underlying state in your body predicting the risk of disease.
Mm. Can we maybe take a step back?
Yes.
What are some of the main causes of chronic inflammations?
Yes. Now, Charlène, when I measure you today, I could ask you a lot of questions because we actually know a lot of things. It could be, do you feel lonely? But I would, because we actually recently published a study on loneliness that's actually also giving you chronic inflammation. It's quite interesting, but that's one study. First of all, I would say that what we looked very much into is the usual suspects, and that's the diet, that's how you exercise, that's if you smoke, that's how much alcohol you take in. And what we discovered was that I had a brilliant doctor, Peter, who did a study on where we looked at 6,900 Danes, where we had a really excellent food questionnaire. It's what we call the dietary quality score. 9 means we interviewed a lot of people and we divided them from 0 to 9, whether they 0 if they were very unhealthy in their eating, burgers, chips and fries and all that, carbohydrates, a lot of carbohydrates and fat, that combination, up to a lot of vegetables, fish in the other end. And what we discovered was also, I think, really exciting. We actually, now you're from England, we published that in the British Journal of Nutrition. We saw a linear association between how unhealthy you eat and your suPAR level. Actually, for the very unhealthy, 0, 1, and so on, until 6, very unhealthy gave you a lot of suPAR. From very healthy to extremely healthy, they were kind of the same, but very linear associated. So if you eat unhealthy, if you live off fast food and that kind of and not a good diet, then you will get some more chronic inflammation. What are we talking about? 0.3, 0.4, 0.5, half a nanogram higher, and that's maybe 30%. Now, so that's quite a lot. You can also take smoking, which is the most powerful inducer we have of chronic inflammation. So people who smoke, they have elevated suPAR of 1. And I had an excellent medical doctor called Thomas Haupt. He did his PhD on suPAR in the general population. And he had the question, he said, okay, Jesper, we know suPAR is associated with high risk of disease in the general population. We know that smokers have higher risk of diseases. And so let's make a score. Let's look at this. And what we did was first we looked at in this, we had 12 years of follow-up in 6,900 individuals. And he was sitting with the data. He was very good at also doing all the statistical analysis. And he came in and he knocked on my office and he said, Jesper, you want to hear something crazy? I said, sure. When I do a Cox regression analysis, that's what we normally do because you can adjust for age, for instance. And you look at smoking, age is an important factor, right? You always have a high risk of dying if you're very old. So we always adjust for age. But when he looked at smoking, of course, smoking was associated with higher risk. But when he adjusted it for suPAR, doesn't matter if you smoke or not. Smoking didn't mean anything, prediction of diseases. Now, that might sound a little bit crazy what I'm saying, but it's because if you smoke, you have higher suPAR, and it's captured in your suPAR. It also captures your diet. It also captures your exercise level. So suPAR is kind of like it's only one protein we measure in blood, but this state of chronic inflammation is actually taking everything you experienced in your life into one biomarker that gives you that chronic inflammation. And it actually, what it gives you is then also your pace of aging. So the more chronic inflammation, the faster you age.
Mm-hmm. So I understand that fast food or unhealthy food, hyper-processed food would correlate to high suPAR. What about exercise level?
Yeah. Well, exercise is really, for me, it actually changed my life. We had some people studying suPAR and exercise, and it really matters. I mean, if you don't do any exercise, you have 0.8, 0.9, almost as much as smoking, 1 nanogram, higher suPAR than people who train a lot. Then you have the groups below those who have a sedentary lifestyle. That's people who, we had people riding a bicycle or taking the dog for a walk and so on. Getting, the 4,000 or 5,000 steps every day. They had significantly lower suPAR than the very sedentary lifestyle. Then you had people who went to fitness and jogging and all these kind of things, again, significantly lower than those who took 4,000 steps a day.
Right.
And then because the study was very big, many thousands of individuals, we also had professional athletes, people really, and again, a linear association. And the more you train, the lower.
Mm-hmm.
And I think there's both cardiovascular training is important and muscle training is important. And when you train your muscles, of course, you stress them, but it's also the stress that makes you stronger. But you also, doing muscle training, you use the muscles produce something we call myokines, which is anti-inflammatory. So we saw a strong association between this. The one thing in the 4 big ones in lifestyle, which is how you eat and exercise and smoking, and then the last one is alcohol. No association with alcohol.
That's good news for the Brits. Good news.
Well, yeah, I think really actually we saw slightly higher suPAR levels in people who reported not drinking at all. But we don't really understand that group. I mean, it is big population service, and we didn't go too much in it. But I think not drinking at all might be because people have medicines, are not allowed to drink, or they've been alcoholics, I don't know. And then there was a Finnish study on suPAR where they looked at alcoholics with and without liver damage, and the difference was huge. If you have liver damage, you have suPAR in the double digits.
Right.
But if you don't have liver damage, we don't see a difference between whether you drink 1 or 2 or 5 or 6 pints of beer or whatever you drink per day. So that was quite surprising. But the 3 other factors are quite important. I'm not saying that you should start drinking too lot, because if you drink a lot of alcohol and damage your liver, you will. That's really bad. But it seems like when we drink red wine or whatever, beers and whatever we drink a little, it's not bad for us in a chronic inflammation kind of way.
You've just made the French country very happy.
Vive la France.
Exactement. I do have a question around stress.
Yeah.
Have you tested population that were hyper-stressed versus low stress? I'm thinking here especially about, let's say, John listening to us today, who has quite a good diet. He eats very well. He does work out regularly. He does have a couple of glasses of wine a week, but nothing excessive. But he's super stressed.
Yeah.
He works in an office environment that is really high intensity. He's constantly under pressure, deadline, KPIs, constantly anxious, doesn't sleep very well, just constant work pressure.
Yeah.
Almost a few steps away from a total burnout episode. Would John see an impact on his suPAR level?
I think he will. Now, it's been very hard it's hard. We've discussed a lot. How can we measure suPAR and stress? How do we define stress? Because it's also very different from different people. But Line J. Hartmann Rasmussen, who's a molecular medicine postdoc, and she's been working many years out of Duke University at Terry Moffat and Avshalom Caspi's group. They asked that question. They said, suPAR. Now, suPAR is so strongly associated with speed of aging and risk of disease. What about stress? How can we look into stress? And they have these wonderful cohorts also. And our cohorts, again, these collection of people that are in studies. One of the bad things about those cohorts in Denmark, as we talked about a little bit before, is that you are invited and you may say yes. But the guy who sits down on the bench drinking a lot of beers and don't have a place to sleep, he will not get a mail either, and he will not participate. So we have what we call bias, a little bit of bias by having the most healthy individuals always in our population study. And in New Zealand, some brilliant people in the early 70s, 72, 73, started what's called the Dunedin study. It's a lot of scientists have heard the Dunedin study. There's more than 1,500 publications on this group of individuals that it was a cohort study including pregnant women. And it's their children we have been following since 72. More than 1,000 children were born that year in that city, and they were included. And now they are 52 years old. So, and we know everything about them from their childhood, adverse events, they are, for every 7 years, they are deeply monitored. They're flown into New Zealand, even though they live in London or wherever they live. Getting MR scans, we know all about their genomes, economics, preferences, whether it's sexual, that we know their bank account. We know what their friends think about them. It's the most investigated people in the world. And in that cohort, we also had some idea of stress. And in the study where they were looking, I was also co-authoring it, but it was my idea. We were looking into whether stress was affecting chronic inflammation. They defined stress as life stressors, because that's something we know gives stress to people. That could be if you're getting a divorce. That's a stressful situation for a person to be divorced. Or if you go bankruptcy. Or if you're in a life-threatening catastrophe.
An accident.
Yeah, an accident. So there were 8-9 different ways to define things that are life stressors. And that was a way to, and what we saw were that for every one of these for the more of these things you have in life, the more chronic inflammation you have. So it seems like going through a lot of things that stress you in life will also impact on your level of chronic inflammation.
Right. So the more stressors you have, the more chronically inflamed you're likely to be.
Unfortunately, not very fair. Actually, a biomarker like suPAR is not fair at all. It's we see, for instance, in Denmark, that people who live in the north of Copenhagen, where all the rich people live, compared to south of Copenhagen, where you have a little bit more lower income, that they have significantly more suPAR than they do on the other side of the city. Like we can see it in the SIP numbers, right?
Would that be access to resources?
It's probably because you live more unhealthy. If you don't have so much money, you eat more carbohydrates. It's cheaper. You eat less ecological foods. You maybe take less good care of yourself. Now, this is speaking very general, and it's not to be offending.
I understand.
People who live on. My football team is the one out there, so not on. But it's interesting. Also, the longer education, the less chronic inflammation you have. So it seems like the better you take care of yourself. But everybody can be exposed to periods of high stress, and it affects you. So when we discovered that, we also, of course, we came with the question, so is chronic inflammation then here to stay? Can you recover? Should you take better care of yourself? I would say definitely, first of all, and this is important, yes, I would take a suPAR test. We then measure the suPAR. We calculate into a biological age for the client to be, get an idea. If you are super stressed and you have chronic inflammation, you will be older in your biological age than your chronological age.
Can you explain that perhaps for our listeners if they're not familiar yet with chronological age and biological age?
Yes.
And I know that your chronological age is 60 and your biological age is 52. Is that correct?
Yeah, hard work, I'll tell you.
Hard work. So can you tell us what does that mean in case somebody's not familiar with the concept, and how did you get there?
Okay. I have to go back to the Dunedin study to talk a little bit about what suPAR does to your aging. So the Dunedin study was this birth cohort where we followed people from they were born, and they're now 52 years old. And they are flown in for all these investigations every 7 years. So at age 38 and 45, they were flown in, and we measured their suPAR levels alongside this, heavily investigation of their teeth, of their MR scans, of their brain and full body and all that. We know so much about these people. And what we discovered was, so it's almost 1,000 individuals, and what's really amazing is that there's a retention rate of 95%. So even though they're born into this, people have, they stay in this investigation. They know they add value to humankind. They are guinea pigs, but they have said, okay, we can see it has changed American law, for instance, on crime study from the Dunedin. Because if you do crime as a teenager, it was shown in the Dunedin court, it doesn't mean that you are doing crime as an adult. It's a period of your life, and they changed American, how you penalize young people because of those Dunedin studies. But at 37 and 45, one of the things, of the many things we do, is take a picture. So you take some nice pictures of people, black and white, and of all 1,000, and then you have two committees, one that is told this individual is 45 years old. You think this person, you grade how old, how young do you think this person look? Or you are not told how old the person is, and you have to put across the other committee of 7 people. So we call it facial age. So they judge the individual's facial age. They don't know that this is a 35-year-old person. They say, okay, this looks like a 52, this looks like a 37, this looks like a 45-year-old. And what we saw was that the more suPAR you had in blood, the older you look, right? And then we correlated also the suPAR levels to their VO2 max, to their lung capacity, to their biomarkers of their liver, their kidney, their heart, to 18 different of the most important biomarkers that Daniel Belsky has developed. I think they're both biological age predictor, really good. We correlated suPAR to all that, and we could see that for if you were in the top 20%, the 200 individuals with a higher suPAR, they age around 1.2 year per year. So they look older, they age faster. And those who are in the lowest quintile, they age by 0.85 year per year. So the more suPAR you have, the faster you age. And when we put people in the brain scanner, we could also see that the higher suPAR they had, the older the brain they have. The correlation between the gray and the white matter shows an association with the aging brain. And actually the professor there was really, thought that was crazy, because first time you saw a biomarker associated in blood, a systemic in blood biomarker associated with the aging of the brain. So now we know the higher the suPAR you have, the faster you age. But what is an expected suPAR level for you, for instance, right? Because it is so that, first of all, women actually have higher suPAR than men.
Oh, great news. Yeah. Thanks, Jesper. You just made my day.
Well, until around 75, then men actually pass women. And we don't quite understand. We think it's something to do with the muscle mass, that, men have more muscles, produce more myokines. But it doesn't matter. It's not like you have a higher risk, because we normalize your suPAR level to your age and your sex.
Right. Okay. Yeah. So what is really important is to have a baseline or a starting point so that I can track. So for instance, my personal journey vis-a-vis suPAR is to have a baseline, some data point that I would take now, and implementing some holistic lifestyle choices or decisions or micro habits, and then track again in some time to see where I'm at vis-a-vis where I was.
Exactly. it's a good baseline, and it gives you a good idea of your overall health and is what you're doing working and so on. But just to finish it up, then we in Denmark also have a lot of volunteer blood donors, and we measured 9,300 for their suPAR level. So we know what a blood donor would have as a median suPAR. A woman your age, we won't talk about your age today.
Oh, we can.
But you're so young, so, right? But let's say that you were 35 years old. I would go in, see a woman with 35 who's a blood donor, would have hundreds of blood donors your age. And then the median, I would say your chronological age is equal to your biological age. If your suPAR hits the median of Danish blood donor women at your age.
Interesting.
But if your suPAR is higher, we actually saw, it was interesting because these 9,300 donors, it was a medical doctor doing a PhD on depression, and she said, does chronic inflammation underlie depression? So she measured all these blood donors, and then she followed them for 5 years on whether they got prescribed medicine for antidepressant. And it turned out, the higher the suPAR you have, the more likely you are to get antidepressant medicine, which all the data I'm talking about you can find in peer-reviewed literature at PubMed. Depression and suPAR, you'll find many papers on that.
But that's quite incredible, isn't it? That there is such a strong correlation and that we could use that tool as a predictor, but also a preventative measure.
Yeah.
Because I'm just thinking about Caroline here, who takes her suPAR test and finds out that she has an elevated suPAR.
Yeah.
One could therefore decide that the best course of action for Caroline might be to get therapy or counseling or coaching in the next few years, because she's more likely than the average person to have mental health difficulties or challenges. And
burnout
therefore,
and
right.
Yeah, because that systemic chronic inflammation drives, everything, depression and so on. So if you are up there, I mean, what's wonderful about suPAR is that it's like a yellow flag, right? It's an early warning.
Yes, but I just want to go back to this story. It sounds to me that this biomarker, that one blood test that indicated elevated suPAR, led this patient to actually have this intervention, but she would otherwise not have known, right? It would have been missed.
Yeah.
So
Yes.
what does that mean in terms of prevention? Let's think about cancer, cardiovascular disease.
Yeah.
How helpful can suPAR be vis-a-vis prevention and vis-a-vis empowering one to have that yellow flag, as you say, right?
Yeah. Well, I think for me personally, and for many I know, it's a really, it's an early warning. It gives you an idea of your risk. And maybe personally, I'm not that fond of really healthy living. I actually like fish and chips and burgers and stuff. So, but I call it intelligent living in a way. If you monitor, it's an early warning for all these different diseases. And if I have elevated chronic inflammation, I measure mine regularly, like every 4 or 5 months. Also a little bit dependent on how I'm living. But then I also take action. I mean, okay, it's elevated. Damn, I gotta, pull myself together, right? And I actually had quite a high suPAR at a time point when I was 59. And and that's when I really pulled myself together because it was too high. And I was turning 60 and, I wanted to see if I could drive it down. So I used half a year of diet, of really, healthy diet, of sleeping well, of exercising. And I brought my suPAR down linearly for every time I measure it over the next month. And I got down to 52 years, and I probably could go even further, but maybe I need drugs for that. That's our next big research question, of course. Can we take drugs but that's another. But I think it's an early warning. And I also feel that if you're stressed out and you're on the way to burn out, and maybe chronic, it's not that we have a lot of data on burnout and people who are stressed, but we have this life stressor, and we know that suPAR in general. And I think if you have really hard work, and when you're stressed, and really working hard, I think you need a fit body. You need a good body that works beneath you. You need an immune system that keeps you well. And that way, if you have, a lot of work pressure and a high suPAR, you're probably going down as we see even in blood donors, high risk of depression and so on. So for me personally, it's really valuable in, guiding my life. And we have also done, the experiments, not that high scientific. There's like TV shows, right? People who go to high grade of longevity, or they go through more holistic mindfulness, sitting in a mountain, yoga and all that. And all that seems to actually help also. But it's mostly on in Denmark, it's part of TV shows sometimes. You take 5 fat chefs and then you put them through a program and you measure suPAR before and after and you get an idea, did this work, right? Or people who are really fine to longevity, eat tons of supplements and all these kind of things. But we need bigger scientific studies on that. But I think it's a really good way to just take a test and to see, is my overall health okay? Am I okay inside? Can I continue being, high performer and all that? And I may be feeling stressed, but it's okay inside.
Yes, but can you tell us a little bit more about the correlation between chronic inflammation and metabolic disease, such as type 2 diabetes, cancer, but also the connection between chronic inflammation and cardiovascular incidents?
Yes. First, many good papers also have shown, very many from the US also, shown that high suPAR associated with cardiovascular disease. We were the first ones to show it, but they have been done huge studies since then. And that also makes us question, so what is the role in cardiovascular disease? We also know, as we talked about in the beginning, low-grade inflammation, chronic inflammation is a driver measured by hs-CRP or the CRP protein of cardiovascular. That opened our doors. But if you, for instance, are born, there was a paper in New England Journal of Medicine where you found individuals who have a genetic disposition to produce high amounts of CRP. Are these people at elevated risk? Have high CRP, but no, they're not. Because CRP is not playing a role in the pathogenesis. But in big studies, not so many have genetic variants that give them high CRP. But CRP in itself is not taking part in the pathogenesis of cardiovascular disease. But suPAR actually is. So we did a study where we measured suPAR in 14,000 Americans and 14,000 Danes, and we did a full genome screening, looking for genetics in the genome that was associated. Are some people born with higher suPAR? Is there part of my suPAR that's not only smoking, but a genetic disposition for higher suPAR? And we did find one biomarker, or one genetic mutation actually located in the suPAR gene. And this mutation was in around 10% of individuals, and it elevated suPAR around 0.3 nanogram per mil. That's
quite significantly.
Yeah, quite significantly. Quite significant. Not as much as low. If you stop smoking, you decrease by a nanogram. But it's like the difference between really working out hard and not doing anything. So 10% of individuals have a little bit higher suPAR. And then we took that to England. You have the UK Biobank, which we appreciate a lot. You have more than 350,000 individuals in England that are genotyped. And we asked, if you are Englishman and you have this mutation that gives you slightly higher suPAR, is that then associated with increased risk of disease? And it turned out it was associated with, now I don't have to say associated, it was causative of arteriosclerotic and cardiovascular disease. Meaning that if you are born with higher suPAR, you have higher risk of calcification of your veins. So suPAR in itself is an early warning for cardiovascular disease because chronic inflammation is, but actually this biomarker is also causal. We published that in Journal of Clinical Investigation, and we also supplemented that with, mouse experiments where we overexpressed suPAR in mice, and we could see that their arteries became calcified and so on. So a lot of evidence, and also in New England Journal of Medicine, 2 papers showing that suPAR is causative of kidney disease, which was also confirmed in the UK Biobank. So a high suPAR is associated with high risk of cardiovascular disease, and bringing your suPAR down by lifestyle intervention is actually beneficial for you because suPAR in itself is a causal factor in the pathogenesis of cardiovascular disease.
Right.
Yeah. And it's also highly associated with your risk of developing kidney disease. And you can read those wonderful papers in the New England Journal of Medicine showing, the reason why they got published, in one of the best journals in the world, was suPAR was the first biomarker in blood ever to be able to predict your decline in kidney function, the eGFR.
Right.
So because the problem we have with kidney disease is that when you get chronic kidney disease, we don't have biomarkers that can predict it. You get it, and then we can measure biomarkers of kidney damage. You have kidney disease. Damn it, you need to go through dialysis. You have,
That's almost too late.
Yeah, and why didn't I know that? And that's actually chronic inflammation also that leads, but also a causal effect of suPAR that binds to the podocytes, which are cells on the kidney, and destroys them. And that's what these New England Journal papers show, and also with supplemented mice experiments inducing high-expressing mice are getting kidney failure. So, and then you have the cardio-renal axis. So actually your cardiovascular, your heart and so on, and your renal function are very tightly linked because of if your kidneys don't work, you don't get rid of all the things in your blood that you should, and it stresses your whole cardiovascular system. So these things are also quite linked. And your last question with regard to diabetes, I mean, there's insulin sensitivity and chronic inflammation is also very tightly linked. And diabetes, type 2 diabetes, is strongly linked with, we have many papers have shown that if you have elevated suPAR, you also, but that's the metabolic part of it. And it's interesting with the metabolic actually, because we all know one of the primary risk factors for type 2 diabetes is BMI.
Sure.
And actually CRP is a really good biomarker of metabolic health because the more obese you are, the higher the CRP you have. Now it's difficult to measure CRP on a day-to-day basis, but it is actually affected by your metabolic inflammation. You could say CRP is a biomarker of metabolic inflammation. And suPAR is less affected by your BMI because suPAR is linked to your immune cells and not to your fat tissue. It's the communication between cells and the immune activation. It's how your T cells and so on, when you look at activated cells, it's whether they're all over the place all the time and they're signaling and they're talking. And so chronic inflammation measured by suPAR is cellular inflammation, while CRP is more it's a metabolic inflammation, saying that you're overweight and you should lose. It's not that I'm saying there's not an association between inflammation measured by suPAR and obesity, because if you're very obese, you have higher chronic inflammation. But is that because you don't exercise and you don't eat so well? I don't know. So so suPAR is a good biomarker also and it will be slightly elevated if you are 25 to 30 and a little bit more 30 to 35, but not much, but above 35, then we start to see. And it's a U form. So people are very low BMI also have a little bit higher suPAR. And that's not also very good if you're below 18 or something like that.
Sure.
But it's not so affected by the BMI as the CRP. But that also means that it's not only metabolic inflammation measured by CRP, but also the cellular inflammation measured by suPAR that drives diabetes and cardiovascular disease.
Can we talk about the connection between suPAR and lung disease, such as asthma, for example?
Yeah, I don't really have. We did look at the risk of developing asthma. We didn't see anything. There are lots of papers on COPD, but that's different, like the higher suPAR, the worse COPD, and so on, and readmission, all that. But asthma, couldn't really see anything.
suPAR and anxiety, depression, we covered a little bit, mental health in general.
Yeah. There's a lot of work on suPAR in psychological diseases as someone responds. So in general, what we see is that people with schizophrenia have quite high suPAR levels. So they may be around, my normal population is 2.5, they are like 3.5, 4. But we also, I'm convinced by these studies because it's also seemed like schizophrenia patients, they have a much higher degree of smoking, kind of help them with their difficult mind and all that. But definitely, it seems like people with those kind of diseases have higher suPAR. And it also seems in a study we published recently on schizophrenia patients receiving treatment that those who have a high suPAR have a better response to the treatment. And that's probably because they're more ill, I guess. And it also brings the suPAR slightly down when you respond to the treatment. And then neurological diseases, we don't have very much data. I mean, if you look at if you read Peter Attia's book about the 4 horsemen, so we are very strong on 3 of them. And the 4th one, we talked about those cardiovascular, diabetes, so on. But the 4th one, the neurological disease, we don't have so much data. But I know that Albert Einstein, Alzheimer's cohort in the US, bought a lot of suPAR kits. So I know there's ongoing measurement in one of the most famous Alzheimer's cohorts, and we're very excited. But there was one study from Salim Hayek's group at University of Texas that didn't show a high association between neurological diseases and suPAR. It was a big study, but it wasn't very positive on that. So right now it seems like with the current data, we don't have strong support for suPAR predicting Alzheimer's disease. On the other hand, it's difficult with the ApoE4. I did my PhD in genetics and all that, and I also worked as a genetic counselor. I also worked for the European Union in all those regards and so on. But it is a little. We know that it's a hard one. If I did a full genome on you, would I give you the Alzheimer's? Because we don't really have medication. We don't really have anything to do with it. But also one of the talks yesterday and some of the talks at the ARDD conference in Copenhagen, 14 days ago, the Aging Research and Drug Development conference, they talk about that we actually do, if you have ApoE4 homozygous, yes, you have a 18-fold higher risk or something like that, but it does do a difference to exercise and so on. So I would also expect that suPAR would be involved in it because the things that we think help against preventing of Alzheimer's are the same things we know lowering your chronic inflammation. But I have to say that we need more data on neurological diseases. And then we already talked about the depression and all that.
Yes.
Yeah.
Can we go back to the connection between suPAR and how it can be predictive in correlation to cancer, for example, just because it's affecting such a large population more than ever.
Yeah.
And I wonder if you could maybe tell us a bit more about what types of cancer, if any. Do you have any data on that?
Yes.
And how has it been most powerful? Maybe a success story or case study that could be really interesting.
So cancers are really difficult, I think. And I think they're difficult to predict because there was this nice paper in Science a few years ago where they looked at all kind of, genomic predictors, proteomics, all the things we could do in individuals who didn't have cancer and then those who got it. And there are many we can predict. And suPAR can also predict many of them. But there's an element of chance. It's simply a lottery. So one of the causes behind development of cancer are mutations in our genome. And mutations arise every time a cell is dividing. And they divide all the time. Our cells are dying and new are being made also. So you have an ongoing circulation. And maybe I'm just thinking, it's funny with suPAR, the faster you age. So maybe that's why it's linked to development of some cancers. I never thought of that before. But let me get back on track. So your cells divide, and by change, you get mutations in the genome. And we have protective genes. We have oncogenes. We have this system that keeps our cells from not turning into a cancer cell. And if they do, your immune system will kill them unless you are suffering from chronic inflammation because you get cancer every day in your body, and your immune cell kills them. But if you have chronic inflammation, they will at the same time be knocked at all the time, the cells that are fixing the cancer, saying, hey, there's something going on over here. That's what chronic inflammation is, right? You don't have the time for your immune system. It's actually a stressed, overcooked immune system. That's chronic inflammation. But some cancers we can predict. We have shown that we can predict a lot of cancers. Henriette Langkilde was the primary investigator on these trials. So there's quite a few cancers that are associated with low, but there's also cancers that simply develop by the chance of a cell division and a mutation that arises causing a cell to go into becoming a cancer cell. And in that Science paper where they investigated, it was actually as high as 6 out of 10 cancers are by chance. And we all know it, some person that lives really healthy and then suddenly they get cancer. A lot of the cancers we can understand, BRCA alleles, breast cancer, there's a lot of things, we know, and a lot of things we can predict. I actually talk about 3 types of people sometimes, some people don't want to know anything. Some want to know something about what they can do, something about. You can take the BRCA alleles as in there, I guess. Angelina Jolie, for instance, who's a carrier, right?
I did it as well.
Mm-hmm. Yeah. And then you have the people who want to know everything, also all the diseases. We talked about the ApoE4, Alzheimer's, and so on. And there's nothing right or wrong. I mean, there's no reason, maybe if you're young and in good health, why should you do a suPAR test? You could be interested maybe in your biological aging, but, you're not going to get disease the next 10 years when you're young. Some people actually, say, can I get a test? Why? Because you can measure something. I say, sure, but I think you need a little bit of risk. But it's also interesting if you want to age slowly, I guess. I can. But with regard to cancers, for instance, we did really one, I think, really interesting study, and that was, again, Anne Langkilde. So what we do was we looked at a little more than 1,000 smokers. And we know smoking is associated with risk of lung cancer, among other things, but lung cancer, that's what smokers fear. And what she showed was that the higher the suPAR, the higher the risk. In the highest quartile, the first people started in their late 50s to get lung cancer. We followed them for 14 years. And in the low suPAR, the first one who developed lung cancer of these smokers, that was 250 people in the low quartile, was 75 years old. So if you smoke, right, you shouldn't smoke with a high suPAR at least. And that's, again, what I call intelligent living in a way. We might like to, sleep too little, work hard sometimes, really give it, and we know it's not good for us. And we are on the flight, and we eat junk food, and we don't have time to eat, right? We don't have time to prepare, and we are on the run all the time. So maybe, we should be fit to do those kind of things, right? You can live unhealthy for a certain, you can maybe even smoke. Did I say that? But at least if you smoke, you should be sure that you don't have an elevated suPAR, because if you smoke and you suffer from chronic inflammation, so those people who actually smoke and don't have really high risk of getting lung cancer, it's probably because they're really low in their suPAR, right?
Understood.
Yeah, they're lucky persons, right? Nobody can smoke, but we start to understand more and more why some people don't develop lung cancer. And, you see these pictures, people sit and smoke cigars and their 100-year birthday and so on, right? These are exceptions, but we are starting to understand the molecular biology and the things that are behind. Some people are just better fit. And that's kind of what the suPAR test also gives you information on, because it's chronic inflammation. And that's the end result. Your immune system actually is really important.
Yes. Yes, but I have one last question. I'm going to take a test with you today to look at my suPAR. How quickly after that result should I take one again if I am to implement some changes to influence my suPAR result? What window of time does one need to leave to get some tangible result and to implement steps?
So what kind of interventions are you thinking about making? Because that's important for me to answer your question.
Yeah,
because if you stop smoking, we did a randomized control study of people stopping smoking, measuring suPAR baseline, 4 weeks, 8 weeks, 12 weeks. And after 4 weeks, highly significant drop, whether you get nicotine or placebo. It was a randomized study. Nicotine substitution is not bad for you. Nicotine doesn't affect your suPAR level, but it's something else in the smoke, right? But that's 4 weeks, highly significant, 1 nanogram decrease. But if you say you'll eat 2 more broccolis every day, I will have to put the lifespan or the next test further into the future. So what are you thinking of changing?
Well, overall, I think I have a very good lifestyle, but I'm about to find out. We'll see exactly. Well, let's say if I were to make small tweaks, perhaps just be even more mindful about some of my habits. I think it's fair to say everyone can optimize a little bit of their day-to-day habits. So if we have a good baseline, let's say, and we're going to make small tweaks, I don't have any drastic lifestyle decision that I need to change. I'm happily not a smoker, so I do eat pretty well and do work out very regularly. I just got out of marathon training, so I'll be also interested to see if that perhaps had an impact.
Well done,
so if anything, maybe...
We have done studies on marathon.
Oh, really?
Yeah, a half marathon doesn't do anything to your suPAR. A whole marathon elevates your suPAR for 24 hours a little bit. But you have to go that far. And then there was a study from Brazil where they had people running 200 kilometers measuring suPAR before and after the race. And they also had, but their chronic inflammation goes down again. But it's not good for you in the 24 hours after, but in the long run, I think you have to actually damage your body to make it. It makes you stronger. But marathon is a bit on the extreme and maybe not so good for you. It's more a mind thing than a good thing for your body.
I agree with that. Jesper, I'm quite looking forward to those results now. We have mixed ingredients.
But if you change something, maybe 4 months.
4 months.
But if you don't change something, the very good thing about suPAR is it's quite stable.
Quite stable.
If you don't do anything, you will have the same suPAR level in 4 months. Great. But a guy came up to me. I don't know if I should say, but he was showing me this, and he didn't mind. I'm not mentioning his name. But he went from 3 in suPAR to 1.7 in 3.5 months.
By changing?
By starting on rapamycin. And I was kind of, what the... I haven't... So...
No other changes, just taking that.
Yeah.
Okay.
But that's crazy. But that's... we could talk a whole hour about longevity medicine.
Maybe that's the next podcast.
SGLT2 inhibitors, metformin, supplements, NMN, all these kind of things. And rapamycin, that's a big animal out there, right? And you cannot use one guy. But we are doing clinical trials on senolytica right now, using suPAR as the primary endpoint after 4 months. So again, I would say 4 months is what we expect to see change. But and we are also doing rapamycin. We have rapamycin trials in the planning. But I think we are over time, or
we're just on time. So can I ask you, how would you like our listener to connect with you if they had more information or were intrigued or wanted to test their suPAR level?
Yes. So my email address is my name, Jesper Eugene Olsen, in one, and at gmail.com. And I'm on LinkedIn, and I'm on WhatsApp, and I'm on whatever. And I like to engage in discussions with individuals and who use suPAR the way I do it. And we are kind of a community, but we are also getting more and more into clinics around the world. So it's really interesting times for me, and I love it so much because I think suPAR can help a lot of people, because they find they have a high suPAR, those in particular, and they do something about it. And that's, I think, about what longevity is all about. It's about health span. And if you want to improve your health span, you don't wait until you get a deep venous embolism, or you get an embolism, or you get, diabetes. We know you are getting diabetes 10 years before you get it, right? And it's a wonderful community, and it's all about health span, a little bit about lifespan, but it's all about health span, more or less, 99% for me. I'm also 60. I don't want to have chronic diseases. I keep my parents out of chronic diseases, right? I know what it takes, but it takes hard work pushing my father into, making But I'm monitoring his suPAR and getting it down, right? But he's hired by Danish TV and on TV and so on, and he's in his 80s. And we got to do that. We got to stay fresh. And we have these tools that our parents didn't have when they were, at risk. And so let's go longevity. I mean, have a good life in a still longer life.
Jesper, thank you. And let's go get tested now.
All right. Thank you,
Charlène.
Thank
you. Thank you for listening all the way to the end. As promised, here's the big reveal. My suPAR result came back. I was a little nervous, to be fair, because I was afraid they'll come back poor. I had just a really rough month, recently overcame dengue fever, lots of international travel, and running a marathon. None of those being great factor for inflammation. However, I was amazed and pleased to report that my result was optimal. Excellent, in fact. It came back as a 1.5, which indicates inflammation level deemed excellent. To me, this outcome really matters because it shows that maintaining positive lifestyle habits overall truly pays off. I do hope that my experience inspires you to take a proactive approach to your own health journey and to start tracking your health. You will find more information on Jesper's research and the suPAR test links in the show notes. And don't forget to please subscribe, leave a review, and share this episode with someone who might really benefit from this information. See you in the next episode.